Our today webinar, as Bruno said, is part of a series dedicated to strategic purchasing and is organized by the Collectivity Strategic Purchasing Working Group in collaboration with international organizations such as WHO. And PBF, as you may know, is an important entry point to strategic purchasing in many low and middle income countries, and especially in sub-Saharan Africa. Theoretically, PBF is a dynamic strategy that should be regularly updated, ideally with sound evidence, following the evolution of context of the population needs or merely for the sake of continuous improvement. But actually and in practice, this is not done enough. We, however, think that health technology assessment could be an interesting tool from which PBF and more broadly strategic purchasing mechanism could benefit from, and we are going to see how this is possible through this webinar. So we'll have three presenters. The first one is Laura Downey from the Imperial College London in England, who will present us what health technology assessment is, and she will provide some guidance on how PBF and strategic purchasing experts could improve their processes. After Laura, we will have Olivier from the Ministry of Health of Burundi, who have an extensive hands-on experience in implementing PBF in the field. And Olivier will share with us what has been done so far in Burundi to improve PBF indicators. And lastly, we will have Bruno Michel, who is from the Institute of Tropical Medicine in Antwerp, professor of health economics and founder of Collectivity. And after the presentation by Laura and Olivier, Bruno will make some general reflections and recommendations on how PBF and health technology assessment can go together. So the presentation will last about 45 minutes, 1 hour maximum, and thereafter we'll have a question and answer session in English or in French that will last about 30 minutes. So now, Laura, the floor is yours, and you can begin.
Thank you very much, Joel. So I'd like to start with a disclaimer that I am not an expert in PBF, and I really look forward to discussions with participants and my fellow co-presenters around how health technology assessment evidence can be used to strengthen the PBF process. So I work as part of Imperial College London in the Global Health and Development team. Our team was formerly part of NICE in the UK, the National Institute of Health and Care Excellence, within the international team. So we are the secretariat and core convener of an international network, the IDSI. This network draws on our collective experience of generating and utilising health technology evidence to inform priority setting processes across the globe. So we work very closely with partners from HITAP Thailand, CNHDRC in China, Priceless in South Africa, and the Center for Global Development in the USA. So herein lies the decision problem, where there are always competing demands on finite resources, and those demands inevitably outweigh the budget available. So this is true for all countries, from high-income countries like the UK to lower middle-income countries, where the resources are even more scarce, and therefore the competition for those resources is more fierce. So what health technology assessment is provide a tool for policymakers to weigh up evidence and set the right priorities for where to allocate their health budget. So according to the World Health Organization, health technology assessment refers to the systematic evaluation of properties, effects, and impacts of health technology. So when we speak about technology, we're not only speaking about that in literal terms of things like pacemakers, but also around drugs, diagnostics, devices, and even social care and public health programs. HTA is really about the process, which is technically robust, fair, and transparent. And we often have evidence for clinical efficacy, but what policymakers really want to know is when new technology becomes available, is it worth the money compared to what they're currently spending, compared to all reasonable comparators? So this is operating in a context of health systems strengthening and not in isolation. And this is particularly relevant when we think of the recent WHO policy brief on PBF that points to the necessity to look at the forest through the trees when thinking about PBF evidence. HTA really is about this process of including social values, equity, as well as the best available evidence when explicitly considering and weighing up priorities within the health system. So I've highlighted here a number of areas where I think HTA could add value to PBF, and I look forward to discussing this, and then I'm sure there are many other areas that people may have thought of. So first of all, HTA can add help in terms of explicit assessment of value for money. It can assist in the process of incorporation of new evidence for interventions in a health system where innovation is frequent. And it can also ensure that programs are rewarding the right interventions. So at the core of HTA is the explicit effort to minimize the opportunity cost. And what I mean by that is essentially the health benefits that could have been achieved had the money been spent elsewhere. So HTA is a tool for priority setting and allows one to set clear priorities using a process of best available clinical and cost-effectiveness evidence to weigh up all options of how financial allocation can be spent and come up with the most wise answer, or at least the most well-informed, about how to buy the most possible health and reduce the risk of displacing health or reduce the opportunity cost. So the WHO introduced their policy brief on health technology assessment in 2014 and recognized this as an important tool for policymakers towards their journey for universal health coverage. So HTA is really part of a wider evidence ecosystem which converges in a number of ways in order to support health system strengthening. So on the left, you can see evidence feeding into a system, which may be randomized controlled trials, observational evidence, case studies, which is then synthesized to form the basis of an economic assessment, or HTA. These recommendations about whether a health system should or should not invest in the latest technology, or whether there is opportunities for disinvestment or reconsidering existing allocations, are then diffused further into the clinical system through the development of standard treatment guidelines. These are often further distilled into quality standards and indicators, and then finally further diffused into the system through mechanisms such as performance-based financing or allocating what should and should not be included in health benefits packages. There's also a particularly important role for HTA to play in strategic purchasing, both of services in the way that PBF advocates for, but also of the specific interventions themselves. Thailand is a particularly good example of this, where they use HTA evidence in the price negotiation process. So this slide further reiterates a number of ways in which HTA is a mechanism for weighing up evidence for setting cost-effective priorities to support wider health system strengthening. Again, the forest through the trees. So the process is an important way as it can provide robust and sound evidence to defend difficult decisions when policymakers are deciding whether they will or will not fund certain interventions. Within HTA, it can also be very instrumental in outlining what should and should not be included within a health benefits packages. So we know that donors often use PBF to harmonize their support around a comprehensive benefits package of services, as in the case in Burundi. And HTA allows for an incremental adjustment of inclusions within those packages to update with new evidence and also identify areas for disinvestment. We also know that HTA provides an important lever for quality improvement, again in ensuring that those quality indicators of PBF are cost-effective in themselves, and also informing things like strategic purchasing, reimbursement criteria, training, and other areas. So as I've alluded to a number of times now, the process is really at the core of what makes HTA unique and important. So this schematic here is adopted from Norman Daniels' Accountability for Reasonableness, and really highlights nicely the fact that at the core of HTA is a process that is equitable, fair, scientifically robust, and not immune to challenge and debate. So equity and social values are explicitly considered within the decision-making space. And this is something that Bruno will come on to later in the talk in his slides. So now to move on to some more concrete examples to give you a flavour of how HTA has and could be used to inform PBF. So in the UK, we have a pay-for-performance program called the Quality Outcome Framework, where primary care practitioners are rewarded for meeting quality targets based on a predefined set of indicators developed by NICE in the UK. So these indicators are based on a mixture of HTA and standard treatment guideline evidence generated by NICE. And this forms the bulk of the evidence that goes into defining these key P4P indicators. So to give you a more concrete example, I've outlined here the indicator for asthma management in the UK and how evidence was diffused in order to get to that indicator. So first of all, HTA evidence is considered as part of the guideline development process to ensure that clinical practice recommendations are in line with evidence for cost-effective practice. Again, we often know that new interventions are coming into the system and could potentially replace old interventions, but what we really need HTA for is to help us decide whether or not those new interventions are worth the additional cost. Guidelines are then further diffused into quality standards to allow more easily implementation of clinical practice recommendations into the system and to measure those and ensure that quality improvement is taking place. And finally, those quality standards form the basis of the quality indicators used in the pay-for-performance scheme, upon which general practitioners are provided with financial incentives to meet those quality targets. And finally, economic evaluation in the form of HTA is also important in order to assess the cost effectiveness of the pay-for-performance program in itself. And anyone that's more interested in that, I'd really urge you to read the paper by Walker and colleagues from York University who have done some nice economic modelling around that. So it's all well and good to show how HTA evidence can be used to inform performance-based financing in high-income countries, but what about low and middle-income countries? So this is an emerging area of importance as countries move towards realising universal health coverage and the Sustainable Development Goals. We've started with an example from India, a country where I work very often and spend a significant proportion of my time working with the government, where the government has committed to using HTA evidence as a core component of their UHC agenda. So again, anyone that's more interested in this can look at the paper that I've included here below and also have a read through the new key policy documents such as the National Health Policy in India, which commits to the utilisation and generation of cost-effectiveness evidence, and other strategic vision documents from the Indian Council of Medical Research and the Planning Commission. So the Ministry of Health and Family Welfare recognised that healthcare practitioners in India lacked clear guidance on clinical practice, particularly in the areas of maternal and reproductive health. The inclusion of hysterectomy and RSBY, the largest social health insurance scheme in India, meant that there was a rise in low-value care where capitation payments and a lack of governance for service and reimbursement criteria meant that the rate of hysterectomy rose dramatically to the second highest volume service in India. So we worked very closely with local partners on the ground to synthesize clinical and economic evidence, such as health technology assessment evidence, to inform best practice in clinical pathways to improve both the quality of care delivered as well as the value for money of RSBY investing in these kind of procedures. Now, if fully implemented, these pathways could save up to 17,500 women from unnecessary procedures each year, generating additional money to be put back into the system. So when we think about this in the context of PBF, there is significant opportunity for PBF to add value in incentivizing these kinds of evidence-based best practices and informing the delivery of care. So I've included here another model in the case of Ghana, where my colleague Calypso Chalkadu and Mohammed Gad, Joe Lord and others have worked very closely with the Ministry of Health in Ghana to develop a health technology assessment model for hypertension, which compared the clinical and cost effectiveness of the four main classes of antihypertensive drugs. So this model revealed that diuretics were more effective and less expensive than other classes of medicine, and further that 10% prescription shift from, for example, calcium blockers to diuretics could save the Ghanaian government up to 18 million Ghanaian cedi. So So again, when we think about this in the context of PBF, these kinds of performance-based financing mechanisms could be used to incentivize cost-effective clinical practice in terms of this shift away from less cost-effective interventions towards more clinically effective and cheaper interventions, and highly cost-effective, and not only cost-effective, but potentially cost-saving. So there are a number of challenges in implementing effective or institutionalizing an effective HTA system, particularly in the context of low and middle income countries. And I've highlighted just a few here for further discussion. So how to define cost-effective in itself can be tricky. This depends on how, for example, a threshold for cost-effectiveness is defined. There's often a lack of technical skills in these emerging economies in terms of developing, synthesizing, and using cost-effectiveness evidence, and this requires significant capacity building. Political buy-in in this area also takes significant time to understand and ensure commitment from the government as well as local stakeholders to take part in this consultative process and ensure the evidence is adequately used. There are a number of lessons from HTA that can support a PBF framework, and again, I'm sure I've highlighted only a very small amount of those here, and I look forward to further discussions. But essentially, I think that HTA can provide an evidence basis to further strengthen PBF indicators to ensure that those programs are advocating for a cost-effective practice and good value for money. The HTA process in itself is also incredibly important for advocating for inclusivity through stakeholder consultation and inclusion, is scientifically robust in weighing up the best available evidence for not only clinical effectiveness, but also cost and improvements in quality of life, is transparent according to a clear methodology, and is generally robust. So there are a number of key elements of the HTA process that could be incorporated into the PBF process. I also see an opportunity for reciprocal system strengthening. For example, the pay for performance or PBF programs link payment to data and can thus create demand for and promote investments into health management information systems to improve the accuracy of data collection and enable timely payments. Now, this kind of data is also essential for the development of robust and sound HTA models. So there's a real opportunity there for P4P and health technology assessment to go hand in hand. The WHO also highlight the observation in their recent policy brief on PBF that contexts with greater freedom of public information provides a more conducive environment for pay-for-performance reforms to have the desired effect. This kind of environment is strengthened by HTA, which is a process that really requires transparency and could pave the way, therefore, for stronger and more effective PBF mechanisms. So I'll stop there and pass over to Olivier.
Thank you very much for the floor, Laura. My presentation will be focused on how in Burundi we try to use new evidence to inform our PBF implementation. Regarding quantity indicators determination, before PBF scaling up in 2010, we organized a workshop in 2009 with participants from all levels of the health system and partners. And the aim of this workshop was to determine the quantity indicators in order to ensure that all the minimum package of activities at health center level and all the complementary package of activities at hospital level will be covered. And it was also to put more emphasis on national public health priority indicators according to their burden. And then higher unit fees were applied to these priority indicators compared to others. In Burundi, our PBF is associated to free healthcare policy for under 5 and pregnant women. So we do have quantity indicators related to free healthcare policy for under 5 and pregnant women. And these indicators had to be reimbursed at the real cost. But unfortunately, at the beginning of our PBF in 2010, we did not have any health services cost study to guide us in setting up unit fees for these indicators. So we decided to set unit flat fees, but this raised many complaints from health facilities arguing that these unit fees were very low. And to develop quantity indicators, we used the Delphi technique. In fact, the Ministry of Health decided to choose 7 local experts familiar with the health system. And these experts were given a list of several indicators, asking them which are priorities and more comprehensive for them. These experts also indicated the relative importance of each indicator compared to a basic indicator, which was curative consultation indicators. And later, this relative weight helped us to set unit fees for each indicator. Regarding quantity indicators updates, the first update of our quantity indicators, specifically update on definition of quantity indicators, was done in 2015 due to the fact that we observed many discrepancies between the PBF data and HMIS data. One reason among these discrepancies was the fact that we did not use the same definition for the same indicators. So the Ministry of Health decided to organize. Okay, and then after this workshop, we decided to align our PBF quantity indicator definitions to HMIS definition. And in fact, this role is still ongoing. This year in 2018, we changed also a definition of one indicator, children fully immunized, based on new guidelines from EPR program, which inform us that now the new guideline for fully immunized child is to be considered after the second dose of measles vaccine at 11 months instead of the first dose at 9 months as previously done. And then all modification in our PBF scheme has to be approved by what we call an extended PBF unit, which includes the PBF technical unit, Ministry of Health staff, and partners. Next slide. Regarding quality indicators, we do have technical quality checklists for health centers, district hospitals, and national hospitals. And these quality checklists are based on normative documents implemented in the health sector, disease guidelines and protocols at national level, and strategic guidelines from health programs and national health development plan. And as planned in our PBF scheme, we have to revise our technical quality checklist every 2 years. Of course, the revision or the update can be done whenever it's necessary. And regarding quality indicators, the first update of quality checklist was done in 2012 in order to consider a new harmonized medical file introduced at hospital level by the Ministry of Health, to add also some clinical indicators proposed by health programs. An update was done by a technical team, broad enough, with participants from all the levels of the health system and our partners. The second update was done in 2014 in order to consider a new HIV strategy called Test and Treat, to make some in-depth change of indicators with more emphasis on clinical and outcome indicators. And the review process has also been broad and inclusive enough. A third update of our quality checklist is planned this year, 2018, and will be based essentially on results and recommendations from clinical audits. Regarding PBF budget management, we do have PBF budget for each province, and unit fees for indicators consider equity dimension. In fact, all our provinces are divided in 4 categories based on some criteria such poverty rate, remoteness of the province, indigent people within the province, population and number of health facilities. The first update on our quantity indicator unit fees was done in 2013 based on a study of healthcare costs conducted in 2012, and unit fees, especially for quantity indicator related to free healthcare policy for under 5 and pregnant women were revised. And the second update on unit fees for quantity indicators is planned this year, 2018, after an update on our healthcare cost study, which is planned on the first quarter this year, 2018. We do also quarterly assessment of our PBF budget used for each province, and then we make some adjustments if necessary. So this is what I want to share with you on how we try to use new evidence to improve our PBF scheme. Thanks.
Thanks a lot, Olivier. So I will try to do a quick wrap up, and I will build on the presentation made by Laura and Olivier. So here are really general reflections, which I hope are useful for our discussion. Laura gave a definition from WHO, and I want just to stress a few words. So HTA is a specific country-owned systematic processing of assessing evidence, information, and perspectives to inform decisions as to whether to fund a health intervention, treatment, or service. So I think I just wanted to stress a few words in this alternative definition. So the country ownership, I think today in most countries like Burundi, there is a heavy dependence on partners. So it's WHO, UNICEF, Global Fund, which will recommend to national programs what would be the right package of services and help the countries to develop the guidelines. And this is the information most of the time we will get in the PBF programs, which is good to some extent. It's of course much better than nothing, and we can really trust these institutions. But it's not country owned, and it's maybe not always fully adapted to the country. Even if we know that this process of national guidelines are very participatory, and I really don't want to undermine these global efforts. But HTA is clearly, as promoted by NICE and others, is really trying to have a better institutionalization of this process. And ownership is also really a government committed to follow advices from their national experts. And also it's also a process country ownership is also the country which is proactively looks for updating its system. Why today, as countries, many countries are depending on efforts done at global level, they're depending on momentum set possibly by these agencies. So the systemization of the process could probably be improved. With Laura and Olivier, we have seen several factors which I think increase the need for strengthening HTA in low and middle income countries. It's interesting to notice that the 3 examples given by Laura are from middle income countries. And indeed, in middle income countries, you can expect that there is a middle class which is developing very quickly. And it's putting new pressure, new demands on the health systems for adopting new technologies, new treatments. So this is maybe a situation we don't observe in poor countries like Burundi today, but actually things can move really fast and they can really go quickly out of hand. So this is a strong argument for adopting this, consolidating with HTA. I think other arguments for countries to look for HTA is exactly the kind of program like PBF, where you try to formalize benefit packages, and this requires to make explicit choices. And so I think as there is a growing number of countries moving to social health insurances or PBF programs, for instance, this only increase the need for consolidating HTA at country level. So why PBF would benefit from HTA? Just a reminder, PBF is about, I like to say that it's about three kinds of efficiency: allocative, technical, and transactional efficiency. So what I mean by transactional efficiency is about designing contracts, reducing verification costs, for instance. We have issues of inefficiency with transactional inefficiency in PBF programs. We have heard recently a webinar with Eric Josephson and Mathieu Anthony, who discussed about how we could reduce this transactional inefficiency. PBF is obviously about technical efficiency. We try to push health facilities to perform the best they can, so to work harder, to open their working hours, and so on. But PBF is also fundamentally about allocative efficiency. So it's about putting the money on the right interventions. So my assumption is that we could probably improve on allocative and transactional efficiency in the coming years. HTA suggests to put even more attention to which intervention we reward, which indicators we use, how much we pay for them, and how PBF fits in the whole package of mechanisms. So there is a lot of issues related to allocative efficiency in PBF. So Laura's presentation provides us some guidance on how we could improve our process in PBF programs. But Olivier shows also that there are already some processes in place, actually. So the point is not to blame and say, oh, PBF is really missing the HTA process. I don't think at all. So if we take the Norman Daniels framework, which I found useful here, about I tried to put some colors, and I took inspiration from the presentation by Olivier, even if I believe that Burundi is doing, I suspect it's probably one of the countries in PBF doing the best in terms of HTA, actually. I suspect that some countries have a less well-established process. So we observe that there is inclusiveness. Olivier mentioned how each time they update their system, their indicators or the interventions, they include the different stakeholders, health facilities, partners, district teams, and so on. And I think that's really great. So thanks to this inclusiveness, I think Burundi is about to integrate social values. And for instance, Olivier just presented a slide about how they integrate equity in the payment system. Still, I think the social values are quite implicit. So to put this dimension in green, I would say Burundi could make an effort to make maybe these social values more explicit. There is transparency. There is a PBF website in Burundi. Olivier is really keen to share things. So probably we could make the process even more transparent. These are, I think, progress which could be achieved quite easily in Burundi. So independence, I'll put it in yellow also, because I think the process is definitely today independent from pharmaceutical sectors and these kind of actors. I think the process is also quite independent from specialist medical doctors, who can really be a strong lobby group which distort the priority setting in the country. So I think the PBF program has been very focused on primary healthcare. Still, maybe there is a dependence on aid agencies. So this is something where there could be some improvement. So about challenging, I think it's important that people are about to challenge the decision which are made, to claim for some contribution in the priority setting process. I think there are things being done in Burundi, and Olivier mentioned a few, but again, this is something where we could probably improve. Then I put 3 dimensions which I think are maybe more problematic in Burundi, but probably even more in other countries. First, and it's mainly a question today, do we review enough our interventions of focus? I suspect that we, in the PBF community, we have been too static at that level. We have not updated enough the interventions. There have been some, the global knowledge is updated continuously in terms of new interventions, and also on primary healthcare. It's not only about advanced technologies, and I believe we should be more proactive. The problem, obviously, is to have the critical mass to organize that, and as countries are very depending on aid agencies, we have a problem at that level. And this is maybe something the Committee of Practice could work on. Yet we have noticed from Burundi there is a review process. So do we review in a timely manner enough? So is this process of review fast enough? Again, I believe that we could improve that. As some of you may know, some of you were with us, we organized a meeting in Antwerp in September on family planning and PBF. And the 50 participants had a strong agreement. There was a strong consensus that we could significantly improve the way we reward family planning in PBF programs. But it takes time. It takes time to develop these new indicators. So we are in January and we still have to finalize our report and our recommendations. And it will certainly take time for countries also to adopt these new indicators. And I put scientific rigor in orange as well, because I think there is obviously an evidence base for PBF programs. All of you are very aware of the huge effort done with impact evaluation, for instance. But as I mentioned, probably we miss the mechanisms to make sure that some interventions are added to the package, and sometimes some indicators could be removed, or because we know that the coverage rates are very high, for instance, or because we know that these quality indicators does not matter really. So I think this framework, I found it quite useful to review how we do things today. I hope that the case presented by Olivier from Burundi was useful for you as well. So this is, I think, my last slide. It would be to say, okay, what could be way forward? One would be to say, okay, could we assess, we have had a quick summary about Burundi, could we do in a more systematic way, for instance, in a sample of countries, and do an assessment of how PBF incorporates different elements of HTA processes? So that would be an interesting assessment, I would say. My recommendation would be maybe to use the framework I just used in the previous slide, the one by Norman Daniels, who is a very recognized and famous political philosopher from Harvard, and this framework has been used by others. So it could help us to map in a quick way some areas for progress. And then we would formulate recommendations to specific countries participating to the study, but also to the PBF community in general. Okay, Laura, I think that was my last slide. So I think, okay, so this is a slide which explains you how to participate in the session right now. So we will keep it on the screen, and then I give back the mic to Joël. Thanks a lot for your attention.